And PCOD was a new problem when I was a postgraduate. I'm talking about way back in 70s. And from that particular time, our concepts became slowly clear. And I will share in the form of a frequently asked question by our own patients, and make the things very simple as far as PCOD is concerned. I'm not going to make it complicated at all. As far as polycystic ovarian syndrome is concerned, it is an epidemic in India, and this epidemic is of late, and it is seen in the adolescent urban India. It is not seen in a rural area of our country. And very rightly, Dr. Renu just now mentioned about it, that, the people who do physical work and, their weight are normal, their configuration of body figures are normal, the problem of polycystic ovarian disease is not there. Still, there are so many queries in spite of so many consensus guidelines. You find the consensus guidelines came right from 2000. It started every 2-3 years. There is a consensus guideline on PCOS. And still, there are several queries in the minds of gynecologists, ordinary doctors, and even family members and patient herself. So this presentation I will try to address the similar problem. Now, as for the incidence is concerned, it is said that globally the incidence may be around 12 to 15%. But as far as India is concerned, it is the capital of non-communicable diseases, and that also comes polycystic ovarian disease. And these figures are, from the Indian Pediatric Society. They said that urban India, the adolescents have almost 35% is the incidence in polycystic ovarian disease. Now, again, yesterday, the Indian Diabetology Association has said that, the definition of obesity must change for us. Till now, for any category, U minus 2.5, and it became the category of BMI as far as India and the Asian countries were concerned. And for us, the normal was 18 to 23. And we did not take into consideration, though you find, once you read about it, you said the waist size is equally important. And now it has been said that, this is very, very important. Once we say it is more than 23, it is overweight. If it is more than 27 for Indians, it is obese. And if it's more than 30, it is morbidly obese. Morbidly obese, you can understand from the definition self that, it's an obesity which has got morbidity with it. But now they have said that in case if there is a BMI is is more than 23, but, the waist size is normal, then in that case, you don't have to get worried about it. It's just the lifestyle which need to be sorted out. And once you normalize her weight, her menstrual problem and other things should disappear. You don't have to really rush for medication. And they haven't particularly mentioned about PCOD, but we can indirectly say. Now, they said once you find that the BMI is associated with more than waist size, and what waist size they have said that roughly, I'm subject to comments by the experts today, that I say that, whatever is your height, your waist should be half of it. If I'm 64 inches, my height, my waist should be 32. If one of you is 68 inches, it should be 34. And if you're 70 inches tall, then your waist should not be more than 35. So this is roughly the things. Waist tells you about the central obesity of yours, and it is the central obesity shows that there's increased visceral fat, and that invites the problem of heart disease, type 2 diabetes, fatty liver, and all those kind of things. So I think, it will be very interesting to find this particular full article. I tried to see through the Google. I could not get hold of it, except the headlines of the newspaper was only there. So coming to the diagnosis. Recently, on 2 days back only, we had a talk by Dr. Gorakh on phenotypes of PCOD. And quite a few of us something was straightened for us, something became complicated after his talk. But whatever I understand, just going to make it open for you. As far as the two terms are asked, and people ask very differently, are they same? Is the PCOD and the polycystic ovarian disease the same? The other day, Mr. Gorak said, probably we do not know how to fully say what is polycystic ovarian disease is. He said it is not polycystic ovarian disease, it's polycystic ovary syndrome. I could not really understand about it, but I know the polycystic ovarian syndrome is an extension of polycystic ovarian disease. Because it's a syndrome, it has got additional things with it also. Now, it is a hormonal disorder. And here I just wish to tell you, in the end, what we have learned in so many years, these hormonal disorders are androgens, androgens, and androgens. And this is androgens which really cause the problems. There is a failure of ovulation as a result of these increased androgens. And then they present with irregular periods, they present with acne, they present with excessive hair growth, and even thinning of hair is the result of the same. They do tend to weight gain is there in such patients. It is due to all hormonal imbalance. Though we have in bits and pieces, we know that it is hormonal imbalance. When we talk about it later, we will talk in detail again. How is the PCOS diagnosed in adolescent? So one thing has become very clear once we have read this consensus guidelines of 2018 and now the final guidelines which have come in 23, it has made it very clear that ultrasound is really not important. So out of the Rotterdam criteria, only the two criteria are there. So the diagnosis is based on irregular periods, the clinical symptoms and features of hyperandrogenemia, few blood tests, and sometimes the ultrasound. But ultrasound may not always be reliable in adolescents. That part we already know about it. And that is why it is said that, in the first 8 years after menarche, you need not get an ultrasound. But the unfortunate part is by the time the patient reaches us, she already has an ultrasound with her. Now, as far as 2018 guidelines say that as far the menstrual cycle should be considered abnormal, if the adolescents in the first year post-menarche, anytime one cycle is more than 90 days, it is abnormal. 1 to less than 3 years post-menarche, in case if the cycle is less than 21 days or more than 45 days, it is abnormal. And more than 3 years post-menarche to premenopause, perimenopause. In case if you find the cycle is less than 21 days or more than 35 days, or there are 8 cycles per year, you can say that the menstrual cycle pattern is abnormal. And whenever there's a primary amenorrhea by the age of 15 years or 3 years after post-thelarche, in case of the periods have not started, these are all abnormal. So as far as we people are concerned, this is the abnormality which has come in the consensus guidelines, and each one of us should know about them, and very specifically should know about them. Now, coming to the question, is PCOS and PCOD hereditary? Yes. It is seen if the mother has had a problem, if the sisters have had problems, you have a higher chance of getting this particular problem yourself. Maybe a genetic basis behind it. We have still not been able to lay for sure. As far as the causes are concerned, we'll still say it is largely unknown, but it may be partly a hereditary factor may be there. And it is also seen in the families with diabetes or hormonal imbalance problems, the incidence of polycystic ovarian disease in that particular family gets increased. Now, another question, can thin girls have PCOS? Yes, PCOS can occur in girls of all body types, and the symptoms might differ. But what our experience is that as far as the thin PCOS are concerned, they have hyperandrogenemia is constant feature with them, and they are difficult to treat. What tests are needed to diagnose polycystic ovarian syndrome? Blood tests for hormones, we all know for a long time that there is a reversal of FSH-LH ratio. It is the total testosterone are raised. Blood sugars get abnormal in case if you're obese, it is to the tune of 40%. If you're thin, then you find it is almost 10%. And is directly related to insulin resistance. And then hormones and the ultrasound is necessary whenever the clinician feels it is needed. So screening for metabolic disorders are required. To test whether patient has got insulin resistance. It is said that all patients of insulin resistance may not have type 2 diabetes, but they have a tendency that they will develop in future. Insulin resistance is again basically you all know about it, that we require insulin for for glucose metabolism. It drives the glucose into the cell and then we get the energy. But this particular factor gets abnormal. There is a more insulin secretion, and this particular phenomenon of entry of the glucose into the cell gets abnormal. Then these people have obesity is a feature in case if you not take care, and this obesity weight increases for unknown reasons. Person says, "मैं पानी भी पीता हूँ तो मेरा weight बढ़ जाता है." Hypertension is supposed to be more in such category of people. And when we talk about blood pressure, it is cut off. Till now, we have been taking 120/80. The other day, Gorak said it should be 130/85. But again, there is no consensus on this. Hyperlipidemia, again, you can find two kinds of features are there. The total cholesterol is raised, triglycerides are raised, but when it comes to HDL and all, you find these are on the lower side. Once these people had obstructive sleep apnea, this is because there is a fat deposition in the neck area, and the neck size increases, and that's why they're more prone to obstructive sleep apnea. And they do have emotional problem. We'll talk about it later. And they have body image issues are also quite a bit. Again, Akriti is going to touch on these particular points. We have very bad eating habits, and that's why there is a hue and cry in the government sector that one should eat right in India. This is one of our missions as well. The whole thing is, the quality of life goes haywire. Now, these are the investigations. Investigations are on the left side, they're essential investigations. You can see what is important here. I will give importance to 2 hours, 75-gram OG-TT test and a lipid profile, which has to be done from time to time in such patients. And whenever there is a PCOD or there is hypothyroidism or there is anemia, I think all three things are linked. Anemia, hypothyroidism, and PCOD are linked. So I think the lipid profile, TSH and CBC are important in such patients. Goes without saying that the total testosterone, one must get it done. The rest, which you can see, it depends upon the clinician discretion whether those additional investigations need to be done or not. Now, how do we document insulin resistance? Now, insulin resistance, I think, is a subject by itself. But insulin resistance, I think our fundamentals on insulin resistance should be very clear. I have just very in simple form said that the phenomenon of insulin action on each cell, driving the glucose into the cell and getting energy, goes haywire. And that's why you find the glucose levels in the blood get increased, and there is increased insulin resistance. And sometime we can have a just talk on insulin resistance, what happens. We use the basic test which we use to know insulin resistance is 75-gram OG-TT test. And I think this is mandatory for all of us to get it done. And you find in obese patients, you'll find it is abnormal in good to 50 to 60% of cases, while the people who are a normal weight or a thin patients, you can find anything between 15 to 20% insulin resistance may be found. And this is, we come to know by impaired glucose tolerance. If the blood sugar fasting levels are varying between 100 to less than 126, and the PP varies from 140 to 199. It is desirable to do the test for insulin resistance and to plan the management of counseling and regarding further prognosis. I think this simple test, very cheap test, becomes very important. This is just to show that it is 75-gram glucose load is given to know the impaired glucose tolerance. Fasting glucose divided by fasting insulin with a cutoff of less than 4.5. This we used to use about a decade earlier, but we are not using it anymore now. There is Dr. Gorak talked the other day of insulin resistance. Fasting insulin multiplied by fasting glucose divided by 405 with the cutoff more than 2.5 to 3.5. Again, this particular test is not used, so you should not confuse yourself. You just remember 75 gram glucose test. Now, as far as the management is concerned, our management is focused on these girls and girls and girls only. First question is asked by herself and by her parents. Can PCOS be cured? No. It can be managed effectively by lifestyle changes, by diet and exercise. But जब आप इसको छोड़ दोगे बीमारी आ जाएगी. You find that the thin girls, they complete their families, but then they forget about in happiness. They increase kilos and kilos of weight for themselves, and you find their presentations become like a polycystic ovarian disease. So anytime they can present after puberty the problem of PCOS, and then they require medication and other therapies. Now, as for the treatment is concerned, I think we are confused what we should use, when we should use, how long we should be using it. The clinical manifestation which warrant treatment of abnormal uterine bleeding, which we see in these adolescent girls presenting as irregular bleeding, heavy bleeding, and delayed periods. Cutaneous hypoandrogenism presentation is by hirsutism, which is absolutely distressing to the adolescent girls. And there is a severe persisting acne. Again, they bother them. And temporal baldness also, they are worried about it. The doctors tell them that you have insulin resistance, and they find that the weight, in spite of all their efforts, is going up and up and up. Is weight loss important for managing PCOS? Yes. Everybody says that it's 5 to 10% weight loss does magic. Yes, it does magic as far as the infertility patients are concerned. But I think in an adolescent, if you find a girl who's more than 100, 110 kg, she has to really drastically cut down her weight by 25 to 30%. Then only things are going to be, road ahead will be better for her. Otherwise not. What diet helps to manage these PCOS patients? And I think all gynecologists have very little idea, or the counseling is very poor as far as diet is concerned. Diet should be rich in fiber. Fiber should be around minimum 25 to 28 grams as far as daily diet is concerned. They should lean proteins should be their favorite. Whole grains should be used. Plenty of fruits and vegetables should make around 50% of their diet. And they should say a big no to white sugar. And processed food, they should, again, say big no to their processed food as well. Is exercise necessary for polycystic ovarian management? Yes. The regular physical activity improves insulin sensitivity and hormone balance, and minimum of 150 minutes per week of moderate exercise is required, which should not be difficult for these adolescent girls at all. Now, as for the lifestyle measures are concerned, I have told you about what is the importance of BMI and what is the importance of waist measurements. People also talk about waist and hip ratio also, and it is said that all these celebrities, great ladies, had a waist hip ratio of 0.7 or 0.75. No, that was the kind of figure. So it means उनकी कमर उनके बटक से 70% होनी चाहिए, या उनकी बस से 70% होनी चाहिए, या उनके shoulder width से 70% होनी चाहिए. So this is what is the importance of waist hip ratio. But I just now told you, आपकी height से आपकी waist आधी होनी चाहिए. But this is the best for thin girls who are yet to get married. They should keep their waist size to 32. Now, as for the diet is concerned, I just now told you about, all infertility experts talk about 5 to 10% weight loss to improve, the whole profile in a big way. As far as overweight and obese people are concerned, overweight is whenever your BMI is more than 23, and obese is whenever your BMI is more than 27. And it is advocated that they should decrease 30% of their calories. That is 500 to 700 calories per day has to be curtailed, and the diet of 1200 to 1500 calories is good enough for the day. And individualized approach has to be there. to tailor upon on their dietary, what changes, what they like, what is their food preferences, and we should avoid undue restrictive and nutritionally unbalanced diet. So again, it has to be professional dietitian who should be taking care of them. नहीं डॉक्टर साहब हम कर लेंगे, नहीं हमारा फैमिली में कर लेंगे, हम सबको जानते हैं, उससे कुछ नहीं होगा. Yeah, this is what my experience over the long period of time says, that gynecologists can't decrease this extremely obese patient's figure. Reduce carbohydrate to only 40% of the total calories. Again, I have heard Gorak and many dietitians speaking about it. Low carbohydrate diet. It means it should be mainly high protein diet. They talk about 3 main meals. That is, breakfast should be after 12 hours. Breakfast should not be late. And after breakfast, there should be gap of 5 hours for the lunch and then 4 hours for the dinner. I'm not too sure about these 3 snacks, because अगर वो 3 diet भी लेगी और 3 snacks भी खाएगी तो तब तो पतली तो नहीं हो सकती. Avoid refined carbohydrate, and the sugar should be considered as poison. In fact, white sugar is now considered as tobacco, and this should be given up. Very difficult for people like me to say. We also find that to leave white sugar altogether is very difficult. But I think more and more day, afternoon, and evening, we try to tell ourselves that this has to be curtailed. Then probably we should be able to curtail it. The fiber content of the diet has to be increased by increasing fruit and vegetables, and I say make it 50%. Oats, bran, barley, all these things are. Oats, people can take, but whether barley and all still people are taking, it's very difficult for me to know it. But as far as the increase intake of omega fatty acids is required in the form of fish, nuts, and olive oil. Never skip breakfast, never skip meals. Regular time of meal should be there, and each breakfast within 2 hours of waking up. As for the insulin resistance is concerned, it is said that, and obesity is concerned, it is the first line management and include 30 minutes of exercise every day. Lifestyle modification improves menstrual frequency. The woman starts ovulating, and the testosterone level also tend to fall, and there's improvement in weight, insulin levels, though no improvement is seen in hirsutism. With level decrease in weight, hirsutism का कोई फायदा नहीं होता. Now, as far as lowering the glycemic index of the diet also benefits the insulin resistance of adolescent with PCOS. And it is said that, once the weight of adolescent is decreased, it induces regular ovulatory cycles in at least half of them. Of my long experience with these young girls, which numbers is now in thousands and thousands, once they have normalized their weight, they never looked at us for a conception. They had the spontaneous pregnancies and everything spontaneously. So I think the crux lies in normalizing your weight. As for the metformin is concerned, it is suggested only if there is an abnormal glucose tolerance. If a patient who is PCOS and patient is obese and you do not find an abnormal glucose tolerance, there's no point giving metformin. It doesn't work. Lipid abnormalities of metabolic syndrome cannot be normalized by weight loss. I will touch on metformin again later. As for the AUB is concerned, abnormal uterine bleeding may manifest as irregular, infrequent, delayed periods, or as heavy menstrual bleeding. The treatment of choice for this condition are the oral contraceptive pills, as they regularize the cycles and improve the hypoandrogenic manifestation, both acne as well as hirsutism. So the treatment options, the patient wants to know what all medications will be used in my treatment. So birth control pills, metformin, anti-androgens, fertility medication, if she desires fertility, are commonly used. Now at birth, are birth control pills safe for managing PCOS? The parents often ask. Yes, this is commonly used to regularize patients and manage acne and excess of hair growth. Now, what are the choices as far as the OCP is concerned? OCP with standard progestin, which is there in Malayan and overall, are advocated for adolescents, very readily available for people who are working in the government sector. With AUB alone or associated hypergenic features, they can use these 2 preparations. OCP with drospirenone, which was highlighted again by Dr. Gorak the other day. I say that this is a preferred OCP in obese girls with or without hirsutism, because of their unique anti-androgenic property, their unique anti-mineralocorticoid property of drospirenone, which minimizes weight gain and may in fact have a temporary weight losing effect. So if patient you find that my patient is obese, you find the drospirenone preparations will be better for her. OCP with the ciproteron like Dyne 35, Janet 35, and the desogestrel preparation like Novolon. Again, these are anti-androgenic preparations for girls with predominant hyperandrogenic features. They may have a normal weight. Then you can use these preparations. Now, the important tip is, again, I want to have an opinion of the experts in the end. After a few years, the literature says after a few years, depending on the clinical picture, the OCP should be withdrawn for a few cycles to allow for recovery of suppression of pituitary gonadal function and to ascertain whether the menstrual cyclicity has been resumed or not. In my practice, I usually do it after 6 months or so, because if patient has been brought to me after she has periods of 4 to 6 months, then a minimum time which you need to use it initially is for 12 months, and thereafter, there should be gap after 6 months. Now, as far as the short stature with open epiphysis is concerned, the concept has gone out of the window, but still I will talk about a couple of slides. Progestins are more suitable in irregular and infrequent cycles without hirsutism or acne. Menstrual irregularities where there's a contraindication for estrogen use. Then menstrual irregularities in perimenarchal girls with further growth potential. Which progesterone to use? My favorite is medroxyprogesterone acetate, 10 milligram meprate, or micronized progesterone. People can use it 100 to 200 milligram at bedtime, can be prescribed for 10 days each month to felicitate monthly withdrawal bleeding and, to treat endometrial hyperplasia. Now, as far as hirsutism is concerned, I have just now told you OCPs along with any of the following additive therapy can be advocated for 9 to 12 months, but it's very important to counsel these people, patients and their parents, is that the effect of COC will be seen only at least 6 months after the therapy. Then you'll find that, the hair growth has really decreased, and she notices that my hair growth has decreased now. Now, as for the cosmetic treatment is concerned, whether you advise it or not, they use it liberally, waxing, bleaching, shaving, debilitating cream. There are safe options, cheap options. The drawbacks that, when they overdo it, there's a skin irritation and need to frequently repeat the process. As far as this cream, F-lornithine hydrochloride, it has a great potential. It is available in our country. Once you start using it, the effect is seen in 6 to 8 weeks. I've seen girls using for years and years together, as far as this cream is concerned. As for the laser therapy is concerned, we all know about its usage, but it should be used only once you have used oral contraceptive pill for some time and patient and parents feel that, the growth of the hair has decreased. That is the time to use it. But goes without saying that repeated sessions are required, and that's their biggest limitation. As for the electrolysis, to remove the hair permanently is a great procedure, but you require experts to do this. Again, Akriti is going to comment on this, whether people use it anymore now. And otherwise, when I was Lady Harding Medical College, there was a person in close to Rivoli. He was great as far as this treatment was concerned. Now coming to anti-androgens can be started once you find that the derma interventions do not bring the desired results in 12 months' time. They should always be prescribed with OCP. I again repeat, they should be prescribed with OCP as they may cause menstrual irregularity and because of their potential teratogenic effect. This part must be told, and there is no clear-cut guidelines about the duration of treatment with anti-androgens. The drug of choice with gynecologists I've seen by large is that they are happy to use spironolactone, aldactone, The initial dose is 100 milligram twice a day. Use it for almost 9 months to 12 months, and followed by maintenance dose of 50 milligram twice a day. It works wonders. And the other day, Dr. Gorak told about Flutide, that you should not get scared. The dose available is 250 milligram tablet twice a day initially, and after you find that your results are there 6 months or 1 year down the line, you can decrease to one tablet a day. You can use it. The dose is 250 milligram. As far as cyproterone acetate is concerned, as it's a progestin which combined with the low doses of 2 milligram estradiol in some formulation like Dynet 35, Jain 35, it can also be given in higher doses with any form of estrogens. But the limiting factor is that this has hepatotoxicity. Even Flutide has a hepatotoxicity. All these patients, whenever you give them a long-term treatment, please see to it that you get serum creatinine done and SGOT, SCPT get repeated every 6 months. Now, what is the role of insulin sensitizers like metformin? A minimum of 6 months treatment is required to improve the menstrual cyclicity and the metabolic parameters of impaired glucose tolerance, which may be extended over a longer period of time if required. Baseline metabolic panel should be done before starting metformin because of the rare but serious side effects of lactic acidosis. The same reason it is contraindicated in cases of hepatic disease, renal disease, cardiac insufficiency, and chronic alcoholism, as it can cause lactic acidosis in these conditions. Now, this particular slide summarizes what is the management of adolescent girls according to the phenotype individual PCOS manifestations. If you find that it is a classic hyperandrogenic oligoanovulation polycystic ovaries, if there is a normal BMI, then they should be told about the regular exercise. If patient is obese, then you need to counsel them about the diet modification plus exercise. And as far as the medical treatment is concerned, non-obese patients, you should start them with a low dose of OCP with CPA or desogestrel as the progesterone. And if they're obese patients, you should start them with a low dose of OCP with drospirenone. Add metformin if impaired GTT. I again repeat, add metformin if there is impaired GTT, or there's a type 2 diabetes mellitus, or there's a positive insulin resistant test positive. On obesity alone, people like me hesitate, but it is here, it is an international guideline slide, so this is in front of you. And if you find the second line management is if no relief of hyperandrogenic symptoms in 6 to 9 months, add anti-androgens like spironolactone with OCP. It is said that to start with, you should start with OCP, but if you find that hyperandrogenic features are not decreasing, then you should add almost 6 months down the line this anti-androgens drugs like spironolactone with OCP. Obesity, if it is there, in a morbid obesity, if it is more than 30 now, the good drugs are available. These two drugs are not known now. The good drugs are available, which are pediatric surgery ko takkar de rahe. So I think one of the person can make a presentation next time about those wonder drugs which have come for fighting obesity. Now, as far as hyperandrogenic oligoanovulatory cycles. So first line treatment remains the same. The medical treatment remains the same. The second line treatment remains the same. Coming to the phenotype, which is ovulatory with hyperandrogenem features and polycystic ovaries on ultrasound, again, the treatment is by and large the same. People who are non-hyperandrogenic with oligoanovulation and polycystic ovary on ultrasound, again, the first line treatment remains the same, that is lifestyle changes, but you can give these patients, instead of OCP, progestins for 10 days every 4 to 6 weeks, or low dose OCP in case if the contraception is desired in such patients. And add metformin only if there is GTT is abnormal. Low dose COC if cycle control and not satisfactory with progestins. So this is the summary of the medical treatment as far as the phenotypes of PCOS in adolescents are concerned. Now, question is, sometimes this question is asked by the parents and the patient herself. Is the surgery required for PCOS? Rarely. Ovarian drilling had been an option earlier, but no more with us as far as ovarian drilling in adolescent girls were concerned. It can be considered only for severe infertility for a patient who cannot come for other treatment. Now, I have seen very few people, pediatric surgery has been offered, but yes, if she's 100, 120, and you find that, all efforts have gone, goes without saying that, one should not have any hesitancy to offer these patients. I know about 3-4 people, doctors, daughters, single child, and have had a pediatric surgery. And thereafter, they have become absolutely beautiful girls. They've completed their families without any problem. Now, as for the infertility concerns are concerned for these girls, does PCOS always cause infertility? The answer is no. Many women with PCOS conceive naturally if the weight is normal or with slight medical assistance. Why should I worry about fertility if I have PCOS? Should I worry about the fertility part if I have PCOS? Fertility concerns are addressed when you plan to conceive, not during the adolescence. So I think you should be very clear with them as far as their parents are concerned, that they should really not worry about infertility part at this particular stage. Can PCOS be treated to improve fertility? Yes. Normalize your weight. Medications like ovulation inducers and lifestyle changes can help them in a big way. If IVF is the only option for PCOS-related infertility, parents ask. No. Most women conceive with simpler treatment. IVF is used only in a complex cases, and that also you find in our clinical practice. It is the classical PCOD with obesity plus, that these are the patients who require IVF. Mental health and emotional well-being is, as far as it is concerned, you do find that these patients are stressed and anxious, and hormonal imbalances and physical symptoms can impact their self-esteem and mental health in a big way. Can PCOS cause depression? Yes. Hormonal changes and body image issues can contribute to depression in good 15 to 20% of patients, and anxiety is seen in good 50% of cases. How can mental health be managed with PCOS? Counseling, support groups, and stress relief practices like yoga can help in a big way. Long-term health risk, again, they ask you, does PCOS increase diabetes risk? Yes. PCOS is linked to insulin resistance. All cases of insulin resistance do not have diabetes. But people who have insulin resistance, there is a high chance that they will develop type 2 diabetes. Can PCOS cause heart problem? Yes. It increases the risk of high cholesterol, high blood pressure, and heart disease, and especially if there's a central obesity. Is PCOS linked to cancer? Yes. Irregular heavy periods can slightly increase the risk of endometrial cancer if it remains untreated. Does PCOS affect menopause? PCOS may delay menopause, but can worsen symptoms like weight gain later in life if they're not conscious about it. As for the lifestyles and the myths are concerned, is PCOS caused by eating junk food? Answer is no. But unhealthy diet can worsen symptoms in genetically और हार्मोनली प्रीडिस्पोज इंडिविजुअल्स, जिसकी आपकी जीन्स है, अगर उसको वैसा खाना खिलाओगे तो जरूर हो जाएगा. Can home remedies cure PCOS? No. But natural methods like diet and exercise can improve the symptoms once you normalize weight, because normal weight is 50% treatment. Is PCOS contagious? Again, this question is asked. No, it is not contagious. Can PCOS go away after marriage or pregnancy? Answer is big no. The PCOS is a lifelong condition, but symptoms may improve with age or hormonal changes, provided you become obsessed with that. As for the follow-up is concerned, how often should I see my doctor for PCOS? Follow-up every 3 to 6 months. Help to monitor symptoms and the treatment effectiveness. Do I need regular tests? Yes. Periodic tests like CBC rule out diabetes with 75-gram glucose test. I'm very fond of getting serum creatine, SGOT, SCPT done on these patients who are under medications every 6 monthly done. Lipid profile is also needed in such cases who are obese. Total testosterone may require repetition in case you find these hypoandrogenic features, if they are not subsiding before you add on anti-androgens. It is good to get a testosterone level where we stand. Is ultrasound needed every time? No, it is not needed if there are changes in the symptoms, or your planning, a fertility planning is there. Now, here I just brought this Ludwig's score. As far as elderly ladies are concerned, you can see this is the lower down. Frontal, and then you find the big patch in the center becomes bigger, and in advance, it becomes still bigger. But as for the adolescent girls are concerned, there is a scale of 1 to 1. You find things are all right. आपकी जो hairline है बीच में थोड़ी और बड़ी हो जाएगी, फिर और बड़ी हो जाएगी. This is the way things are. So I think people should become conscious about it. Put it up in your waiting area, so at least people become conscious about this particular thing. And here I just wish to tell you that each one of us should have a modified Ferriman-Galvin score. The new score does not have the growth of the forearm and the legs, and the terminal hairs are manifested as dark pigmented coarse hair. All of us should know the scaling on the upper lip, on the chin, on the chest area, upper abdomen, lower pelvis, and at the back also you should try to see where all things are there. And if you have this on your table, you should be able to score it very well. So these frequently asked questions can serve as a foundation for training modules to empower gynecologists in India with currently relevant evidence-based knowledge to manage PCOS effectively. So I think, with this